Good evening and welcome to the program. I'm Dr. Margaret Fitzgerald, and I am delighted and honored to be with my dear friend and dear nurse practitioner colleague this evening, Vanessa Danino. And I am just so excited to be able to offer this program. So what we're going to do, since we're talking about breaking down barriers and moving forward with the nurse practitioner profession, both Vanessa and I have been nurse practitioners for a minute or two. She is not nearly as long as I have because I'm older than she is. But what we want to do is first start off with introducing ourselves, and then we're going to ask each other questions. So I'm going to preface my own introduction with the following. First, this might sound like, oh my God, could she just knock it off? And it's bragging about what she's done. But one of the reasons I want to do this, and Dr. Nanino will also be doing the same thing, is as follows. We want to give you an idea of what you can do with this profession, because some of you are NP students. Some of you are newer in your NP careers. Some of you are NP faculty who are trying to move along the next generation of nurse practitioners. But what I want you to do is just appreciate what you can do. Like I said, Dr. Margaret Fitzgerald. My background as an RN was in critical care. You name it, I did it. I was nurse manager of an ICU. I did all sorts of other things. And then one day I decided I want to keep people out of the ICU. And I decided to become a primary care NP. Best choice I ever did. During my long tenure as a nurse practitioner, I've been a primary care provider. I have been on faculty and family practice residencies. I started a family nurse practitioner program. I have taught at the undergraduate and the graduate level. I have published a number of books, including one I'm very proud to say was AJN Book of the Year Award recipient. I'm a professional speaker. I am the only nurse practitioner who holds a certified speaking professional designation from the Global Speakers Federation. I am a consultant, author, professional speaker, clinician, mentor, and numerous other things. My practice has been in primary care and urgent care. And there are a couple of things I also do that I'm going to hold on those because as we go back and forth with the questions, two of the activities or the committees that I sit on that I want to wait until we get into the kind of breaking down the barrier type of thing. But long and short, do I do any one thing all the time? Absolutely not. I've never done that my entire NP career, which is why I'm still in the game and I still love what I do. All right, Dr. Pomerenko. I'm sorry, she's Pomerenko Danino. I messed up the last
It's
name.
okay. I answered everything. Hi,
Yeah.
everyone. I'm Dr. Vanessa Pomerico Janino. I'm so excited to be here as well. Dr. Fitzgerald has been a longtime mentor and friend of mine. I'm so delighted that we get to do this today. This is really a topic that is very near and dear to my heart. So I'm very excited about being able to share some of the other things that we have both done with all of you. So I started out as a GYN surgery and oncology nurse. I decided that I wanted to have a little more say in how my patients were treated. I also wanted to help my patients prevent ending up in my unit. And so I went into primary care. I practiced as a GYN nurse practitioner for several years. And then I decided I had really learned just about everything that I could learn about the gynecology piece and really wanted to do more with preventing certain illnesses. And so I've been in primary care for 26 years. I am the lead clinician for diversity, equity, inclusion, and belonging for our health system. And I'm also the chair of the mentorship committee for AANP. And I also serve as the co-chair for DEI Special Interest Group. I've been an author of numerous publications, both articles and books, and I'm also a national speaker, and I teach for review for Fitzgerald Health Education Associates. And before we get started, and I send this back to you, I just have to say a special shout out. One of my former students from when I was a baby instructor is joining us from Australia tonight. So I'm very delighted to see her. She's doing great things down under. So I say a little shout out to Nicole here.
Oh, how wonderful. How
Yes, yes.
wonderful. And I did some work many, many years ago, probably like 20 years ago in Australia with the NP role. And that's been very exciting international consulting work I've done with South Korea, Puerto Rico, Australia, and the Dominican Republic, looking at all of this. So, with that as background, and one thing, you're way, way too humble, Dr. Vanessa. There are a few things that you left out. She is internationally renowned for her work in transgender care and internationally renowned for her work in tick-borne diseases. She practices and lives in like Tick Central. Where did Lyme disease get its name? From Old Lyme, Connecticut, which is how far from where you live?
Oh, 40 minutes.
Yeah, yeah.
Yeah.
So, kind of like tick-borne disease central. And so I want to make sure that people are aware of that.
Thank you.
And so, all right, with that as a bit of background here, let's take it away. And so, Vanessa, you're going to ask me the question first, or I'm going to ask you a
Sure.
question. Let's throw it out there.
So let's start with the breaking barriers piece of all of this. And you've worked, I know, in the same health center for many years.
Yeah.
We work in two very different clinical settings. So what type of institutional or systemic barriers have you encountered in your nurse practitioner career, and how did you overcome them?
Many of the institutional barriers that I've been able to break through have actually, those opportunities presented themselves to me, interestingly, uh, outside of where I practice. But let me just say a few things about where I've practiced. I have practiced in a federally qualified health center in a small, predominantly Latino community about 30 miles north of Boston. And that's actually one thing that you and I share in common is we've both served populations that we are not members of that population. You with the transgender health care that you have rendered, I not being Latina. But both of us have great devotion to the populations that we have chosen to serve. And one of the reasons why, because a lot of people have said to me, why are we staying in the same FQHC for that long a period of time? I said, one of the reasons is it is a place where healthcare providers are treated really equitably. And so the NPs get the same clinical support as the MDs, the DOs, that type of thing. And that goes a long way to keeping people very happy in the workforce. But it also has put me in a position as a primary care and urgent care provider that sees everything that comes through the door, pregnant, little, in the middle, older, that type of thing. And my expertise, particularly in pharmacology, grew over the years with my practice, also from teaching pharmacology. And one issue that arose a few years ago was there was a call from a major HMO in New England that they wanted a member of they wanted an MD from the clinic, MD or DO, to serve on their pharmacy and therapeutics committee. And because what they were looking for was input from a primary care provider to talk about the pharmacy and therapeutics committee as they approved drugs, didn't approve drugs, all that kind of thing. And I thought, oh, okay. Well, I have decades of experience in primary care in an FQHC, and they specifically wanted somebody practicing in an FQHC. I have expertise in pharmacology. I'm going to throw my hat in the ring. And I got back this lovely note from the people who were accepting suggestions for the people. And they said, wow, great credentials, wonderful, great experience. We're looking for an MD or a DO. And so I came up with, I wrote back and I said, oh, MD or DO, is there, I'm here to serve. I've got the credentials you're looking for. May I ask why? And they came back and they said, it was a little more complicated than this. And they came back and they said, we never thought of having an NP on the committee. So what I said is, estoy aquí. I am here. I can help you out. Would you consider this? Because it took changing the bylaws of the committee to get a non-MDDO on there. And they came back and they said, and then I interviewed with them over the phone. And the person I interviewed with, the medical director of the HMO, said, yeah, we really need you on the committee. We need your viewpoint. So long and short, they come back a couple of weeks later and they said, welcome, we would love to have you. So there are two different ways, and then there's a publication that I'm on the editorial board for that was the exact same thing. I said, I'd love to serve on your editorial board. They said, no, it's MDs and PharmDs. And I said, I'm here, I have expertise, I can really help you out. And I don't bring this up because now it's me, and then when I'm gone, there will be no NP on either of these committees. The really important part was first, I don't take no for an answer very well. And I could have just and walked away and said, no, here we go again, not letting the NPs in the door. But what I did with both situations was I said, before I come on board with you, what I want your reassurance is this position will always be available to a nurse practitioner because committees change. Vanessa, this has happened with you, right?
Yeah.
New leadership comes in. I mean, I have survived like 4 medical directors on the pharmacy and therapeutic committee. I keep waiting for somebody to say, you've really been here a long time. Bye-bye. But when P&T meets, I am the only primary care provider. I'm the only nurse practitioner. And that counts. Representation counts. So when they want to hear from a PCP, all the questions come to me. And so that is powerful. And I always feel like when I'm being asked questions like this, I feel as if the 430,000 nurse practitioners in the United States are in a line behind me. And my job is to represent you well. So that's one of the ways that I look at this is be professional in your approach, I-based statements, not saying like, oh, so you don't have an NP on this committee, but to throw yourself out there really as like the servant leader. I am here to serve. I have expertise. I look forward to hearing what you have to say about this. That's it. That's it. And it works, and it's worked in other situations. So what about you, Vanessa? Because I know you have done some utterly amazing things within a very large healthcare system that is associated with a major medical university as well. So tell us about how you have broken down some of those barriers.
So the first thing that I did, and I just want to preface this by saying that when I was a new grad, I just wanted to go out and practice. I had no intentions of being a leader. I had no intentions of being a trailblazer. I just wanted to go out and practice. How quickly things change. But one of the things I did was I was applying for my privileges at the hospital. And as an APRN, as an FNP, I was applying for privileges not only in internal medicine, but in gynecology. And it took them 18 months to grant my privileges. And every month I'd say, when are you meeting? You know, I need to get my privileges. I was working in a solo practice. There was one other, it was the doc and me. And finally, I got, through to somebody, and I had to meet with the community director and then the hospital director. And I said to them, "Can I just ask why this is taking so long?" And they said, "We didn't know what to do with you because traditionally it's nurse midwives that are looking for their privileges. We've never had a nurse practitioner. So we had to figure out what to do with you." So that was one way that I was able to break in and then open the door for many other nurse practitioners to follow so that they could get their privileges in the Department of OBGYN, even if they weren't a women's health nurse practitioner, if they were an FMP like me. So then fast forward many years, I'm working for the health system now in primary care. And, with my expertise in the LGBTQ gender diverse community, when I first went there, I said, I have a very large population of patients that I need to know in my absence, they're going to be taken care of appropriately. And my boss immediately said, "We'll close the office for a couple of hours. You can do whatever training you need to do." And it just happened to be that they were developing a DEIB committee. And they said, "We would like you to be on it." And within a month or two, they appointed me as the lead clinician. And we have, I've lost track, but we have over 140 offices across 3 states. So anybody that needs to
Wow.
get trained in DEIB, especially with the gender diverse population, has to take my educational courses. But that was kind of hard to break into. I was glad that I was able to do it, and it was at a time when DEI was acceptable. But now we've faced a new barrier where, because we receive federal funding, we have to be very careful about our education offerings and that kind of thing. So, when you break down one wall, there's another one right after that that you have to keep
Mhm.
fighting for. So,
And there are personally, there are two ways of looking at continuing to bump up against these barriers. Is one is you can let it exhaust you and you just go, okay, they win, whoever they is, or you can figure out how to work the system like I believe you and I have to the very best of our abilities, to the best of our abilities, and also really really continue to advocate for populations, the specialized populations that we do see within our own practices. So it's exciting. One thing is when I became a nurse practitioner a while ago, there were 26,000 NPs in the entire country. 26,000. And that was more than 20 years into the role. And here's what life was like back then when there were only 26,000 of us. Nobody cared what we did, who we did it to, what our outcomes were like, because we were zero threat. Zero threat. Now we're more than 400,000. We're a force to be reckoned with. So I think it's a really good thing the profession has grown the way that it has over the years. And I also think it's wonderful that I don't run into too many people in the general public these days that don't know what a nurse practitioner is. If they haven't had personal experience with one, they'll say, "Oh, my spouse is a nurse practitioner. Oh, my niece is in school to become a nurse practitioner," something along those lines. So I find that really quite, quite endearing to hear that. All right. So let's go. Let's Vanessa, in what ways do you think the NPs can advocate for themselves in the profession to expand scope of practice and recognition?
so that's a great question, and it just kind of dovetails onto what you were just talking about. I've started out as a nurse practitioner in an area that was very, very much predominated by physician's assistants, and so there weren't a lot of nurse practitioner positions open when I graduated. And I really had to advocate for myself to find a job because I didn't want to be a graduate with all of this education and stay as a staff nurse. So I knocked on every door that I could. I reached out to every one of the docs that I worked with to say, hey, I'm graduating, I'm looking for a job, this is what I can do. And I think that's what we have to do as nurse practitioners. Things have changed dramatically in 26 years since I graduated. But I also think that we're not done yet. I hear from people all the time about, I graduated a year ago, I can't find a job. There might be some people tonight in the audience that are shaking their heads saying yes. So the ways that we can advocate for ourselves is to really knock on those doors to say, this is what I can bring to you. And this is how your patients are going to benefit from this. And then once we start doing that, again, there's strength in numbers. When we were in Connecticut, I was the president of the Connecticut APRN Society when the board of directors decided to go after full practice authority. And the first year we were not successful, but we regrouped, and it wasn't just me. I was just a figurehead. We had a team of very dedicated nurse practitioners, very seasoned nurse practitioners in the state of Connecticut, that we all came together and we got data, hard data, to show this is what nurse practitioners can do. This is our education. These are the numbers. These are the results from the studies that demonstrate our safe practice. And once we were able to give that information and share it with the Department of Public Health and the committee, that's how we ended up getting full practice authority here in Connecticut, because we showed them exactly what we were capable of doing. But it's not going to happen if tomorrow's providers, tomorrow's nurse practitioners don't start advocating and continue the work that we're doing now. How about you? What do you think nurse practitioners can do to advocate for our profession?
I could not agree with what you're saying more strongly. I'm in Massachusetts. Massachusetts had actually one of the more restrictive NP practice acts in the nation. And one of the reasons why AANP considered it one of the most restrictive is we had the language in there of physician supervisor, not physician collaborator, physician supervisor. In any event, here's the ironic part. I have, I had, past tense, because now in Massachusetts we have full practice authority, a license that said I had to have a physician supervisor to have prescriptive authority in practice. I was teaching family practice physicians and physician residents pharmacology. So here's the thing. In one day, one of the residents could go from being my student to my supervisor. Does that make any sense? Makes zero sense. Zero sense. And so what happened was we were one of those states that scooted full practice authority through at the beginning of COVID. And then we it stuck. It stuck. It took a global pandemic for us to get full practice authority. But in any event, right now, if you go to aanp.org, by the way, everybody should be an AANP member. Okay. It's a professional responsibility, right? Right. Okay. I'm off my soapbox on that. There is a map of the United States where the states are either green for full practice authority, like you're in a green state, Vanessa, I'm in a green state. Red for restricted practice, and then yellow, there's something that they don't quite have full practice authority. Sometimes it's something pretty big. But when you look at it, you'll see that so much of the map now is green. You could say, yay, we're well on our way. And we are more than 26 states. I should have looked this up before getting on screen and talking about it. I think we're maybe like 27 states now with full practice authority, plus the District of Columbia has it.
Right.
26, 27, it's somewhere around there. However, it's less than 50%, something like 40% of all NPs are practicing in states with full practice authority. And the reason for this is many of the states that have full practice authority are rural states. You and I live in kind of the exceptions to the rule. We live in somewhat more densely populated states, although Western Mass is really quite rural. But we still have a long way to go. So my for expanding scope of practice, there are a few things that I highly recommend. First, get involved in your state NP organization because I happen to be the chair of the Advanced Practice Committee in 1991 in Massachusetts when we got prescriptive authority for the first time. So I happen to be the chair, just like you, but I stood on the shoulder of giants.
Right.
It had been going on for 10, 15 years, and I happened to be right place, right time. And I remember when everybody was congratulating me, I was like, oh, please, let me introduce you to the people you truly do need to congratulate who have been working on this before I even became a nurse practitioner. So we all need to belong to our state NP association and be active in it. And even if you have full practice authority right now, remember there are all sorts of issues going on to try to restrict our practice and reverse the gains that we've made. And something else I feel very strongly about, if you are not in favor of full practice authority, for nurse practitioners, please remember, most of us are in favor of it. And that might be your internal dialogue. And it might also be something that you could challenge yourself and say, why am I so uncomfortable with being able to do to the full extent of how I've been educated? Why is it I'm uncomfortable without having like a physician collaborator or something like that? And then internally, if you work for full practice authority, and then if you want to have within your practice a collaborative agreement on prescribing, you can do that. You can do that. That's okay. That's okay. Once we got full practice authority, we were given that option. Do you still want to have a physician collaborator, or do you want to practice to the full extent of what you're being allowed now? Three guesses what my answer was. Or as my former physician supervisor said to me, she said, you're kind of unsupervisable. And she said, I say that with great affection. I was like, yeah, I kind of sort of am. But I know my practice. I know my practice. So that's why I feel confident in going without the physician collaborator. Do you have any further thoughts on that?
I just wanted to kind of attach something onto that, and I do respect the fact that there are some people that feel more comfortable having that collaborative agreement, but I want you to just tuck this in the back of your mind because it has happened to a number of people that I know in states where they did not have full practice authority. Case in point, there was a woman in my state that her collaborating physician very tragically died in a motor vehicle accident. She happened to be in a rural area of Connecticut. She could not find anyone who would stay on as her collaborating physician. She did find somebody, and he wanted 1/3 of the collections that she was taking in, and she ended up having to close her practice because she couldn't find somebody. And you always think, yeah, but that could never happen to me. Never say never. Like Peg said, you can sign that collaborative agreement once you get in there. You can decide what you want to have or not have, but it speaks volumes to have full practice authority, especially for our colleagues that want to open up their own practices. So while it may not be something that you choose to do, it's certainly something that the vast majority of nurse practitioners I know want to do. So just being part of your state organization as well as your national organization, I just want you to know if you're not a member, please join because part of the money that you send in as part of your dues goes to the lobbyists, paying the lobbyists who represent us at the state and national levels. And that's where our voice is heard at the table. Now, I know, Nicole, you are working very hard in Australia to get a voice in Australia, and I have no doubt that you're going to achieve that. But it's not an easy feat. But once you start getting your lobbyists And they do get that their whole job is to represent the interests of the nurse practitioners, again, on the state level as well as the national level. The people that we have, the lobbyists that we have here in Connecticut, they do not represent any other medical community except nurse practitioners. So they are very well versed in what we do in terms of our jobs and our responsibilities. So moving into that, what do you think about the intercollaboration that we have? How does that reduce barriers for nurse practitioners in the health settings amongst our non-nurse practitioner colleagues? How can we do that collaboration to help reduce some of those barriers?
Professional respect goes a long way. How respect, I feel very strongly about this, is nothing that should be automatically granted
Mhm.
because of your title or the letters after your name or anything like that. But it should be earned. And one way we earn professional respect is by demonstrating our clinical expertise, really. And that I feel so strongly about. And this kind of, to go back to something you had mentioned earlier, when you first got out of school, and I felt much the same way, leadership was not like top, top, top on my agenda. But when do we start thinking about doing more of these interprofessional collaborations above and beyond simply saying to somebody in your practice, hey, wait a minute, can I run something by you? I mean something above and beyond that, but collaboration that moves the needle in healthcare, takes care of larger issues in healthcare. Once a person gets their clinical legs underneath them, if you will, that is when I believe very, very strongly that you should start thinking of expanding your reach beyond the exam room
Mhm.
to interprofessional collaboration, moving the needle on larger projects. Like, I'm going to go back to the Pharmacy and Therapeutics Committee that I'm on. I can tell that some of these ultra sub specialists that are on that committee turn their head when I speak because they're surprised somebody in primary care is as well versed about the things we do every day: diabetes, hypertension, dyslipidemia, just like the things we literally do every single day as primary care providers, So I believe that that interprofessional collaboration has helped. It's one of my small contributions to kind of raise the bar on the visibility and the impact of NP practice. I really think that that is incredibly important. The other thing is to look outside the doors of your practice. And if you're within a larger healthcare system, as you are, look within that larger healthcare system for interprofessional collaboration that you are able to extend yourself to, because that is just critically important. There is that expression, if you're not at the table, you're on the menu. And we as nurse practitioners have seen that plenty of times, have we not?
So
Is that we didn't have the opportunity to raise our voices and to be able to be heard collectively. I also want to throw in one other thing. Remember, even within healthcare, most people know nurse practitioners by ones, twos, and threes. Most people do not know 3 dozen nurse practitioners. And I always think of this as like comparing it to teachers. We've all been exposed to lots of teachers over the years, right? Whether we've raised children or not, just being members of the community, being in school ourselves. So we know that with teachers, there's the Venn diagram. There are the superstars, some of the people who aren't worthy of the title, and then there are a bunch of solid citizens in the middle. When you know a profession just by one or two people, everyone in that profession will be judged by the performance or lack thereof of those one or two people. So again, we are a newer profession. We're only 60 years old. We have to be up there performing at our highest level.
So, on that note, what kind of strategies would you suggest for nurse practitioners to help, challenge those misconceptions about our role, but by maintaining that professionalism and patient trust? So, in other words, other profession, maybe a cardiologist who might refer to you as a mid-level, or a patient that says, "Oh, but I want to see the doctor." Or when is the doctor going to come in now that you're all done? What do you suggest to our audience here to do about how to challenge these in a professional way?
I just finished talking, so I'm going to throw this back to you, and then I will
Okay.
add what I have to say about this.
So, as a new nurse practitioner, as I said, there weren't many of us around when I first started in practice. And I actually did have a cardiologist who referred to me as a physician extender.
Oh,
And my blood boiled. But I thought, okay, I know him well because I knew him he was a resident at the hospital and I was a staff nurse. And I said to him, "Stop right there." I said, "Please call me what I am. I am a nurse practitioner." I said, "I am not an appendage on your body. I'm not an extension of anything on your body. I am a nurse practitioner and I have my own practice." And when you say physician extender or a mid level, that implies, especially mid level, implies that nurses are low level and nurses are anything but low level. And when I pointed that out, and I did it in a very respectful way, he was a little bit taken aback and he said, "I never thought about it that way. Thank you." And he never used the term again. Just yesterday, I happened to be at a medical appointment and my midwife actually used the term mid level. And I was like, "Whoa, you've been in practice longer than me. I can't believe that you're using mid level." And she said, "Well, that's what the docs here call the nurse midwives and the nurse practitioner here." And I said, "So again, does that mean that nurses are low level?" And again, she said, "I never thought about it. When she was going to school, the term mid level was acceptable." So I think it's all about education. And I think we just have to do it in a respectful way. And when I first started out and patients would say to me, "Well, am I going to see the doctor now?" And I'll say to them, "I just did everything that you needed to have done. I ordered your tests. I'm going to interpret them. I prescribed your medications. I did a complete physical assessment on you, and I will call you when everything comes in." And when they kept pushing the issue, I had to say to them, "This is what nurse practitioners do. We do everything that our physician colleagues do. So, I will call you again when all of these results come back." But what I decided after a while, when I kept getting hammered at what is a nurse practitioner, AANP had a nice little handout that said, "What is a nurse practitioner?" and it had all these bullet points. I copied them, I stuck them in the waiting room so that when patients came in, and I was the first nurse practitioner in our practice, patients would come in and it was already something that they could read in the room. I can't remember the last time I had somebody that said, "So am I going to see the doctor now?" Because as you said, Peg, our profession has grown that people know who we are now. But I still think
exactly.
some people in the audience probably still get am I going to see the doctor next, depending on where they're practicing.
I'm a big, just to kind of tag on because you covered that so brilliantly. I am a very, very, very big believer in using I-based statements. Like if somebody would refer to me as a mid-level provider and that effective communication, when you start your sentence with the word I, you just became the most powerful person in the room. You did. And there's something, even members of my family cringe when I pull this one out. If I look at somebody and go, "I'm confused by your statement." And that really puts a person on notice. I hear you call me and my nurse practitioner colleagues mid-level providers. I ask you, what do you mean by that? And you might say, you might get somebody who comes back and says, well, that's just a term I've always heard. And I will often say that, well, what does that mean then? Is the RNs are low-level providers and the physicians are high-level providers? And if somebody comes back and goes, yeah, but the physicians, I'll say, it's the right healthcare provider for the person at the right time. And an example I will often use is I don't know how to take out a gallbladder. I have no interest in learning how to take out a gallbladder. The surgeon is not skilled in taking care of the patient who needs their gallbladder out, that I diagnose they need to have their gallbladder out when that patient has hypertension, type 2 diabetes, dyslipidemia, hypothyroidism, and a thought disorder. But I'm very, very, very skilled in providing that person's primary care. And then when you do it that way, sometimes they go like, oh yeah, it's just a different skill set. It's a different
Mhm.
skill set. But when that person needs their gallbladder out, the surgeon's the right person to do that. You know, I take care of everything up to
Right.
going and having your pre-op visit and having the surgeon go, yep, you need your gallbladder out. And thank God there's the surgeon. But if I'm not there feeding the surgeon patients, then the surgeon's not going to be very busy, right?
Right.
So this is like mutually beneficial to both of us. But you know what? I'm with you though. This mid-level business, well, first of all, it's in federal law because if you read the DEA regulations, it's in there. And to unpack it from federal law is we don't even want to get into how complicated that can be. So it's still around. But the other thing is, I have to say, I'm equally uncomfortable. Well, not quite equally. I'm almost as uncomfortable with the terms advanced practice providers or advanced practice clinicians, APP, APC, which a lot of people use. Because here's one of my thoughts. Most of the time they talk about NPs and PAs. How much time does it take to say
Right.
NPs and PAs? Sometimes there are nurse midwives or whatever, because usually the CRNAs are not part of the quote APP group. It's
Right.
the NPs and the PAs. Just call us that. Because also NPs, PAs, we come from two very, very, very different disciplines. There's a lot of overlap in the old Venn diagram on what we do clinically, but we are socialized and educated into very different systems.
Exactly. Exactly. It was a great point. So we can talk about this all night, but I'd like to move in now to how we build expertise, especially for those people who are either still students or are newer in their practice, or even people that are maybe had taken time off and are now coming back into practice. I was very lucky. I had you as a mentor from the time that I was a student, and so I want to ask you how you think or how important mentorship is in building a nurse practitioner expertise. And what does that mentorship look like?
Oh, I think mentorship can look a bazillion different ways. There is particularly again somebody newer to practice as an NP overall, like more recently out of school, or the person who is switching from maybe primary care to cardiology or primary care to neurology, or the other way around. I seen that over the years. They've been in subspecialty practice and now they want to do primary care or urgent care or whatever it is. So there's that clinical mentorship, which I very strongly believe needs to be part of the orientation program. It needs to be laid out in writing of how it's going to happen. And if you're interviewing for a position and they're like, oh, well, we're all here to help you. We're
Mm.
all here to help you. That's wonderful. That's wonderful. But once again, the I-based statements. Oh, I am so pleased to hear that. I also would like clarification on who will be available for me as a in-house consultant or whatever sounds right to use when you're having issues of a clinical nature. Because sometimes what you need in practice is, I mean, you literally need somebody to tell you where something is stored or something along those lines. But it is critically important that you have a clinical mentor within that. The other thing is my role at this point in my career has been mentorship of people outside of my practice. And I have this thing, I call it my micro mentees. And there's a long, long list of them. I love every single one of them where we touch base on occasion on whatever. I'm just wrapping up mentoring somebody to apply for FAANP. I wrapped up a young woman well, I don't think I'm quite done mentoring her yet, but a young woman who worked in the condo building that my husband and I live in Boston, who caught my ear one night about her desire to go into nursing. Anyway, I can hardly even talk about it. She just passed her psych mental health NP
Hey.
exam. I could not be more proud of her. I can hardly even talk about it. I always get choked up when I talk about her. Um, but sometimes mentorship sounds like a job, if you're an experienced clinician, or maybe you're not even as experienced as a clinician, but you're newer to nursing and you had a leadership job before you became an RN or an NP. Um, Mentorship can sound like, oh my God, we have to have scheduled meetings and we have to do this. Extend yourself to somebody that you want to see thrive and say, I'm here. Can we just touch base, get a cup of coffee, go out for a glass of wine every now and again, whatever works. Log in on Zoom and let's talk about your professional development. And that is intensely, intensely rewarding. I feel incredibly strongly that, you know, we've heard this, um, to whom much is given, much is expected. I have been given a lot. I didn't come from a family with money. I'm first generation to go to college. Many of us are. Many of us are. I'm a community college grad with a doctoral degree. That has worked out pretty well, hasn't it? I also feel incredibly strongly that I can't just sit back and say, okay, done my job, done my job. Helped more than 180,000 people along with my team pass their NP boards. Done. No, 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 I can't do that because I've been given so much by this profession. I have a tremendous obligation to give back.
So that's so true of you because you do make sure that you have availed yourself to so many different people. But also mentorship, and I have to put a little plug in here as the chair of the AANP mentorship program. It is a free program, but it's also for people that maybe you have an interest in maybe policy development, or you want to learn how to publish an article, or you want to get more involved in, I don't know, education or a different aspect of not just clinical as well, is being able to find somebody that you could call and have them kind of guide you on. And it should just really be more of a relationship that works for both of you, that it doesn't need, like you said, it doesn't need to be a job. It has to be something that's mutually agreeable. You can meet as often or as little as you want, as long as the two of you are getting out of it what it is that you need to get out of the particular relationship, and make sure that you have a plan and that you have a kind of a finite end to it, to say, we're going to do the next 12 months, but ultimately, as the mentee, what would you like to see yourself accomplish? Is it that you'll have something that's ready for publication, or that maybe you write your first testimony? So mentorship looks a lot of different ways, and it shouldn't be something that is that, like you said, looks like a job. It really needs to be something that's
Yeah.
mutually beneficial. And I have to say, of all the people that I've mentored, I still have relationships with them. And it's wonderful when I hear from them to say, hey, this is what I'm doing. And they all make me very proud with the work that they're doing, because I know that they're going to continue that forward momentum that we need in our profession.
I
So
also never enter into a mentorship relationship with somebody without being very clear that my expectation is they pay it forward.
exactly,
Yeah.
exactly. That's so true. So I know we're starting to run out of time, but there's a couple of
How
things.
could we run out of time? We
Yeah,
just started talking 10
I
minutes
I
ago.
know we got 10 minutes left. So I want to talk about some barriers that you might have faced, or maybe a barrier that you might have faced that made you stronger as a clinician in your career. Can you think of one or two?
Um, a lot of this had to do with the barrier of not having full practice authority that I really did feel like held me back, held the whole profession back. And so I would more than anything else say, you know, turn it around to what we were talking about earlier with full practice authority. And just a word of warning on this one. I've had many, many, many NPs contact me over the years and said, I was in a full practice authority state, needed to move, decided to move. I went to a state without full practice authority. I didn't think it would have any impact on my practice. I can't believe how restricted my practice is. So that's just a little word of warning on that. But what I would say is many of the barriers go back to what I also said earlier about having a seat at the table where an NP has never sat before, and then just deciding I'm not taking no for an answer. I'm not a good person on taking no for an answer when I decide that I've got something in my noggin. But I believe those are some of the major barriers. And it did make me a stronger clinician because what it did was, and a better leader, I believe, because what it did was it made me appreciate never take anything for granted. And the other part, representation matters.
Exactly. And I know I felt that way too, is that when I was joining the group that I'm with now, and one of a physician, not in my particular practice, but one of our sister practices, made a derogatory comment about one of my gender diverse population. And I stood up to them in a public forum and said, I'm not asking you to accept this. I'm asking you to treat patients all the same. And if that's something that you can't do, then you have to ask yourself why you're even in medicine if you can't accept people for who they are. And what that did was it actually solidified my standing. I was shaking in my boots. I'm not going to lie. I think I was working there for 2 weeks when they said, we'd like you to come in and do something. And I had probably 40, 50 people there, and I was shaking in my boots, but I had to do it because I felt like as a clinician, somebody needs to be the voice of these patients. And that's
Absolutely.
and that's really like that's when I was always very passionate about my patients, but that's what really solidified my standing to say, you don't have to accept it, but why are you a physician if you're not going to accept patients and their differences? So
Exactly.
ultimately
Exactly.
we have to be able to be the voice for our patients because some of them are too afraid to speak out.
And again, you and I have both served populations
Right.
of groups of which we are not members. And that is a particularly privileged place to be accepted by a community where you are not a member. I
Mhm.
take that incredibly seriously within my practice. And I never take it for granted that I'm automatically going to be accepted. I've worked hard to earn acceptance within the population that I've been privileged to serve. And that's just kind of like another little thing. I always tell people if you want to survive in primary care, you have to fall in love with the community you serve.
It's so true. That's so true.
Otherwise, you will go up in flames.
It's
And I'm not saying that I don't have my moments where I'm like, okay, okay, this is tough, but 99% of the time it's incredible, incredible work to do.
I
Incredible.
agree.
Yeah.
All right, so I want to try to squeeze in one more question, and then I'll look at some of the questions here in the chat. But what's the one skill that nurse practitioners need to develop in order to stay relevant? Because we know in healthcare, our practices are changing, healthcare environments are changing rapidly. What's that one skill you think nurse practitioners need to have in order to stay ahead of this?
Communication. Very, very, very high level communication skills. In the advent of no one talking to each other anymore, texting and all, to have very high level written and verbal communication skills. I was talking about the I-based statements and all. It's going to put you way, way, way ahead. That needs to also be coupled with clinical expertise. Own it. Own your practice. Own what you do by a strong knowledge base and strong clinical decision-making skills. How about you?
Well, I agree, communication, but second to that would be time management skills. With more and more changes being put on us, you're not seeing enough patients, you need to see more patients. We're going to cut down the amount of time you can spend with patients. You have got to have good time management skills. And if you don't, work with somebody to figure out how you can manage your time so that you're not spending 20 hours a week documenting on your own time. I will say that I'm very fortunate. I learned time management skills early on. My notes are closed at the end of the day. Every time I learned a new electronic health system, I took time on my own to develop my templates and my dot phrases, and it saves me a ton of time. So time management skills are really, really important because you don't want to just be doing this, typing while your patient sees the back of your head as you're typing. You need to be able to have that eye contact with your patient. So learn how to type without looking at a screen and look at your patient and do your time management, even if it means using Dragon or one of the AI recordings, however you have to do it. But spend the time with your patients, make them feel that you're spending time with them and not just with the computer.
Absolutely. And AI can be your friend.
It can be,
It can be
absolutely.
your friend. Don't, my personal feeling is have it be like the coach at your side rather than, from on high telling you what to do next. Okay, that's my feeling about it. But it can be a very valuable coach on the side. All right, so one last thing. How do you feel we're shaping healthcare as nurse practitioners?
I'm a little biased, but I have seen the growth in nurse practitioners across the country because I'm fortunate enough that I get to spend time with a lot of nurse practitioners nationally. And I have seen this huge growth since I became a nurse practitioner 26 years ago. We are the future. We know the data is there that the number of physicians going into primary care is so low that there is a physician shortage. And who better to answer the call to primary care shortages than nurse practitioners? So
And
I
I
we are
also do want to speak on behalf of our blessed founder, Dr. Loretta Ford, who unfortunately we lost earlier this year at 104 years of age. In 1965, she and Dr. Henry Silver, a pediatrician, conceptualized the NP role because they were concerned about children, that's where we got our start, having barriers to healthcare. So what we want to always do is, yes, there is a physician shortage, but why do we really exist? We exist because people in need of the care we can provide exist, and they're only growing in numbers. So I always like to make sure that we focus in on the patients in need. And one of my favorite expressions is NP knowledge equals NP power. We will always be as powerful as we are knowledgeable about what it is we do.
and never to forget the nurse and nurse practitioner.
Bingo. And
That's one
Dr.
of the
Ford,
biggest skills that we bring to our profession is that we listen to our patients. We know when it's time to hold their hand or, be able to just have that nurse, that bedside nurse never leaves us. And I think patients appreciate that because we definitely spend more time with our patients, especially at the bedside, but we still bring that skill with us to whether we're in primary care or specialty care. So, all right, so
Absolutely.
let's see. I got a couple questions here. One person put in here, another concern is the pay. Organizations will use you are a new NP with only experience as a registered nurse. Can I tell you that makes my blood boil when I hear only a registered nurse? So they want to pay nurse practitioners less, and this is really kind of something I'm very passionate about. Do your homework on comparative salaries. Find out what they're offering in your area. Find out what they're offering nationally. Go to a few different websites and get 3 or 4 different salaries, average it out, and that's what you ask for. You would never pay sticker price on a car, I would hope. Most people are not paying the price of a house, the asking price of a house. You always want to not just renegotiate, but you always want to counter offer when they get, and they almost expect it because if you accept the first
Absolutely.
offer, then they know you're going to be a soft sell and it's going to set up the stage for the future when you want to ask for a raise. So don't be afraid to counter offer. If you lose the position because you counter offered it, you have to ask yourself if you really wanted to work there. So that's how
The
you can change that.
one other comment I would make, AANP has salary information. You go in there and dig around on their website, you'll find it. The other thing is, and takes a little bit of kind of digging through it, but I just did a keynote presentation in Sioux Falls, South Dakota, and I was able to go there with salary data from Eastern South Dakota and Western South Dakota, compare it to the national statistics, salary.com, very helpful. And last but not least, Forbes.com, their cost of living calculator. And just to give you an idea, in Sioux Falls, South Dakota, if you make $110,000 a year and you want to move to Midtown Manhattan, you need to make $289,000 a year. It's just, oh, okay. So that almost $300,000 salary looks mighty good until
Right.
you start figuring out what the cost of living is in your new location. I've got those numbers fresh in my head because I just did them the other day.
And
So,
also, too, if you ever get a survey where they ask about your salary, almost all of them are confidential.
yeah,
Please fill them out because when we give talks about salary negotiations and helping people to negotiate their salaries in their contracts, we need that data of what people are making because that's the only way that we're
absolutely.
going to drive the salaries up in our profession, for sure.
Absolutely. And be on the business side of the table.
Right.
You can't pontificate that, I read a salary survey and I deserve to make $150,000 a year when you're only seeing 10 patients a day
Right.
or whatever it is. What you have to do is figure out productivity contributes to this. And as an employer, I will also say is that it's sometimes easier as an employer to grant more benefits than it is to bump up salary. So you might want a bump up in salary, but maybe more CE funds, couple more CE days, few more vacation days, something along those lines can be really, really, really something that you can look at as quite helpful as well.
So true. Okay, well, I think that was really about it. I think we got all the questions in here. So if there's any other questions, put them in the chat right now so we can take a look at them.
Can I throw something else in there about
Please.
the new RN or the new NP? I hear this all the time from people. I'm just a new NP. Knock it the heck off. All
Right.
right. You're a nurse practitioner who has recently become certified and looking forward to starting your career. Don't do this, little meek, whatever. Um, I don't buy that your RN experience does not translate to the NP role. Because one of the things that when you've been an RN, you've done some leadership. Oh, people will say, no, I haven't. Yeah, you have. Wherever you're the lead RN or in charge, did you work with NP students as an RN? Those are all leadership activities. Take credit for them. And the other part is remember what you learned from your RN role, even though I do admit a lot of it doesn't seem to translate. How are you dealing with families in crisis?
Right.
You're rock solid. You're rock solid. Okay. That is a transferable skill. How are you with time management? You're rock solid. How are you with dealing with multiple demands simultaneously with limited resource? You're rock solid. So these are all transferable skills to the NP role. Now, do you have to expand into your new role? Absolutely. Absolutely. But take credit for what you have done.
Exactly. And don't say just, say, I
Yes.
am a nurse practitioner.
Get that word just right out of your language. Or as somebody came in and interviewed with me, well, I'm green. And I was like, what are you, Kermit the Frog? But what she meant was she was new in the role. And I was like, oh, honey, no, don't say that to me. Don't say that to me. That's not a good thing to say in an interview. So,
True.
all right. Has anything else come in?
I don't think so, but thank you all for taking some time to
Thank
be with
you.
us
This has been
tonight.
delightful.
It really has been. And Peg, as always, it's always wonderful to work with
It's
you.
always wonderful to work with you, Vanessa. She
Everybody have a great
is an
night.
international treasure.
I should be saying that about you.
So,
Thank you.
and welcome to our colleague from down under.
Yes, she's going to do great things in Australia. I have no doubt.
Wonderful. Wonderful.
Everybody, thank you and have a good
Thank
night.
you. Take
Bye
care. Good
now.
night.